We have not to lose time.
No.
Thank you very much for coming.
Thank you very much. My CV is too long because I am too old. This is accumulation of the years over the years, so it's not important. Thank you very much, Professor Thessaloniki, for making it possible for me to come again to beautiful Thessaloniki. I've been here before, and of course I admire the work that you've been doing over the years in the field of dementia, that the world, all the people in the world who are interested in Alzheimer's disease know about your contribution. So congratulations on this excellent meeting again. So we've dealt, and I've heard several lectures here already about Alzheimer's disease and what one should do, and also some of the studies that have been done and performed, and the attempts, ongoing attempts to solve this problem. But we must be clear that we are not doing that well. So Time magazine had it that there is some progress, but I don't see this progress, I must admit. When we talk about dementia in general, you are aware that there are many disorders that have dementia as representations: Alzheimer's disease, vascular dementia, frontotemporal dementia, synuclein dementia. And please note that here everything is in plural. So of course we know that there are many synuclein dementias. There is Parkinson's disease with dementia and Lewy body disease, diffuse Lewy body, many frontotemporal dementia depending on genetics and so on, several vascular dementia, but also Alzheimer's disease, I think, is more than one disease. I hope I will convince you at the end of the lecture that it's wrong to talk about Alzheimer's disease as if it is a single neurological entity. So what is Alzheimer's disease? We all know this definition, and we know that it is a complex problem. But it's complex even in the definition. Even the definition shows how complex it is, because it says that this is a clinical pathological entity of progressive dementia with specific neuropathological changes. Now, I don't know of any other disease where the definition of the disease demands both the clinical and the pathological part. Both the clinical and the pathological part. So there must be something unusual to demand us to have this combination. So this shows one aspect of the complexity of the problem. We know the pathology, both in amyloid and in neurofibrillary tangles, and looking for a magic bullet now for several years. So I've been there before any of you came around, and cholinergic loss, trophic factor loss, aluminum toxicity, and this and that, a long list of attempts to find a cure, how we're going to get rid of Alzheimer's disease. The latest here at the bottom is tau hyperphosphorylation, amyloid toxicity. I will talk mostly about amyloid toxicity today. And you know that trying to get rid of the amyloid several years ago, drug giants thought they were to be given up on Alzheimer's cure after spending more than $25 billion on trying to find a cure, how to eliminate amyloid. And if so many clever people spend so much time, so much money, there must be something wrong there if they fail. And I think that everything that we see this failure, we must think that maybe this is based on incorrect assumptions that are being put at the beginning. So I wrote this many years ago, or 5 years ago, and but it's still not changed much. Whatever I want to say now is already in the paper, so if you have to leave, it's there. So several incorrect assumptions, I will try to enumerate one. The first one is that it is easy to diagnose Alzheimer's disease. Well, what we teach our students, we teach them, or residents, we tell them, well, the person must have memory impairment, must have another cognitive domain affected. This must not be just minimal, but rather relevant to everyday life, gradual onset and course, and lack of focal neurological signs. This is how we want the diagnosis to be made. However, this is not so, because if you look at the best centers in the United States doing all the sophisticated tests, the people who then go on to have autopsy show a failure rate of 30%. So 30% of what the experts in the United States say, this patient has Alzheimer's disease, the pathologists say, no, you are wrong. 30% for the most. So it's not easy to diagnose it. And the reverse is also true. It's not only the false positive, it's also the false negative. So these people whom pathologists say, I see in the brain Alzheimer pathology, and the clinicians say, no, the person was okay cognitively. So both positive, and false negative. So the question is, everybody knows who this guy is? Okay. Vladimir Ilyich. So he said, he was talking about the gold standard for the economy, and he said this is wrong, but we must not believe everything that he said, but we must pay attention. And the gold standard that we use, that we say is pathology, may also not be so accurate, because there are several reasons I can show you why pathologists do not always tell us the full truth. Firstly, they cannot diagnose dementia. So if they see the brain, they say, I see here vascular changes, so I call it vascular dementia. But the person was not demented. I see Alzheimer's changes, but the patient was not demented. So if they cannot diagnose dementia, how dare they say what is the cause of the dementia that we see? It's not easy. And many other reasons. We don't have time to get into each of them, and I will mention some. So of course, pathologists have the last word. So I can tell you, I don't know about Greece, but in Israel, definitely in my home, my wife always has the last word. But this does not mean that she is right. So what are the defining features of Alzheimer's disease? Of course, the amyloid plaques and the neurofibrillary tangles. Is that it? Is that it? Is that it? No, we are losing the big picture. The big picture is not that something is being deposited. The important thing is something is lost. The loss of tissue is the important thing. Who talks about this? About the loss of neurons, the loss of synapses? I mean, this is what we see in comparison. So it's not because there is something which is deposited there. So what about cell loss? What about synaptic degeneration? What about white matter lesions? So here is a paper, an important paper from Brain for a couple of years ago, showing that it is what characterizes the dementia of Alzheimer's disease is not the plaques or tangles, but rather the cell number changes. The cell number of cells that remain, this is what characterizes it. And many years ago, Bob Terry and Bob Katzman and Eliezer Matzliach mentioned that it's synaptic loss which is the most important thing. Now, of course, this can be done, can be measured now. The number of cells can be measured, the number of synapses can be measured. They could measure it in the last millennium. But people don't do it now anymore. Why? I mean, so pathologists have a problem here. White matter changes, we don't see in the routine pathology report. We hear about neurofibrillary tangles. We hear about plaques. We don't hear any quantitative mention about the white matter changes, which we know occur very often in patients with old age dementia. And another paper, more recent, from Chicago group. Much of late life cognitive decline is not due to the common neurodegenerative pathologies, is not due to amyloid, is not due to neurofibrillary tangles. And another one from the MRC in England, again, the same thing. George Sava was the first author here. Very important paper. So the next incorrect assumption is that amyloid is responsible for the dementia. Now, of course, there is an association, not a very good one, but there is an association between the occurrence of amyloid and the dementia. But association is not the same as causation. And if some of you do not understand what I mean, I will give you an example. There was a recent paper in the New England Journal of Medicine in which investigators looked at the amount of chocolate being used in different countries and the number of Nobel laureates. And surprise, surprise, they found a strong correlation. So a very, very strong correlation between the two. Now, of course, there are outliers. We all know why Germany did not have many Nobel Prizes in the last century. This is known, clear. We don't understand, I don't understand why Sweden gets so much Nobel Prizes. This is an enigma. Anyway, the fact that there was this correlation did not convince any government to give for free chocolate to the kids in the hope that they will give the country more Nobel Prizes. So correlation is not the same as causation. So this goes back to the amyloid, and again, that's already almost 10 years ago that I wrote this paper about the failure of the amyloid cascade hypothesis. But this is where so much money has been invested over the past 20, 30 years. So that Alzheimer's disease is associated with amyloid deposition. This is so by definition of the entity, as we mentioned before. But to say that it is caused by amyloid, this is an implication. This is a theory. And theory has to be proven, and has not been proven anyway. So I mentioned before that I don't think that there is only a single entity of Alzheimer's disease. So what poor Alois Alzheimer defined in 100 or so years ago when talking about presenile dementia. And he specifically said, this is what I see in Augusta D., who was a young person, 50 when she got sick. This is different, said Alois Alzheimer, from what I see in old people. In old people, I see something different. This is what I see there is cerebral arteriosclerosis. It is similar in phenotype, but it is different, he said. Now, over the years, this has changed. So now we say about it, say it's the same, what happens in old age, but it's not. And the fact that we're paying so much attention to amyloid is because of genetic findings that trisomy 21, people who have trisomy 21 are more likely to develop dementia in the early 30s or 40s, and this type of dementia declined from the previous level, which was not very high to begin with, is due to deposition of amyloid, and they show the same pathology as Alois Alzheimer's patient. And in both cases, this was young onset. And people who have APP mutations, same thing. So APP mutation, amyloid protein precursor mutations, were the signal to show that something is wrong with amyloid. And indeed, in these cases, there was overproduction of amyloid, but maybe the genetic mutations are mislead us when we talk about sporadic Alzheimer's disease. The genetic forms are young onset. They have somewhat similar clinical manifestations, but some differences. But this does not mean that they have the same etiopathogenesis. So it's incorrect to say that the sporadic Alzheimer's disease follows the same pathogenic roadmap as familial presenile Alzheimer's disease. And in fact, what happens in senile dementia is not that they have overproduction of amyloid, but rather there is a problem in removal of amyloid. So it's a different pathogenesis, and this is important. So then there is this incorrect assumption that transgenic animals mimic the important steps in human neurodegenerative diseases. And of course, there are many transgenic animal models taking APP mutation carriers or presenilin mutation carriers and implanting them, the mutated genes into mice and getting a model of what? A model of the early onset Alzheimer's disease, not of the late onset sporadic form, of course, because that's where they came from. But these animals do not have, if you just put the APP or presenilin genes, you get amyloid deposits in the brain, but no tau deposits. You want to have tau deposit, you have to add additional mutation there. So this is the transgenic models, and they do not have neuronal loss. There is very little inflammation there, and they don't have dementia. So none of these mice, when they became old, needed to be cared for, needed to put in an old age mice facility. They could all still walk around, get fed. If you do special tests like water maze tests, you can see some differences, but it's not a progressive decline. So they don't have the features that define dementia for us. But the important thing is this assumption that if we get rid of the amyloid, you will heal the brain. And several attempts have been done to get to this target that you may have heard about. But I think that targeting therapies against amyloid or tau, for that matter, aims at downstream markers, not at the causative, but at the downstream markers of the disease. And they may not be pathogenically important. So how is amyloid related to sporadic Alzheimer's disease? I think it is mainly an epiphenomenon. This is an effect of aging, a manifestation of aging. So we all age, and there are some changes that occur, and some of the changes have to do in the skin, some with the hearing, and some in the brain. And the changes that take place in the brain include amyloid deposition, among other things. So, and of course, as I said before, people may have a lot of amyloid and not become demented. So if I fall dead now, which may happen, and you will perform an autopsy on me, and the pathologist will say he's full of amyloid, you will not say, we knew it. Because so many people have a lot of amyloid and are not demented. And then there is this issue that I mentioned before, that amyloid is a single disease entity. It's not a single disease, but in order to explain to you what I mean, we have to understand what we mean by a disease. What is a disease? Is Alzheimer's disease a disease? Why do we call it a disease? What is a disease? So to illustrate the point, I will ask you whether hepatic cirrhosis is a disease. Who thinks that hepatic cirrhosis is a disease? Nobody. Who thinks that it's not a disease? Okay, and the others do not think. The majority here do not think. This is those who think that it's not a disease are right. And so, Magda, why is it not a disease?
Many other causes cause.
Okay, the same phenomenon can occur due to many different disorders. So, of course, you can prevent hepatic cirrhosis by immunizing yourself against hepatitis. This is easy. You may prevent yourself from having alcoholic cirrhosis if you move to Saudi Arabia. There, by law, you are not allowed to have. You cannot have alcoholic cirrhosis. And so on and so on. There are many different ways. But all these type of hepatic cirrhosis, all these type, have the same thing, have the same manifestations. They have the same clinical manifestation. They have the same biomarkers, bilirubin, transaminase, and what have you. And they have the same pathology. So having a common clinical manifestation, clinical picture, having the same clinical or pathological picture and having the same biomarkers will not make it necessarily a disease. What is a disease? A disease, of course, diseases do not exist. There are no diseases. There are sick people. Disease is a concept, is an abstract concept, which means, and we talk about a disease when we understand what is the pathogenic mechanism. Only then can we talk about a disease. And if there are different pathogenic manifestations for alcoholic cirrhosis and for hepatitis-induced cirrhosis, these are different disorders and have to be dealt with differently. In order to prevent them, we have to understand what is the cause, what is the mechanism leading to it. And just having the same clinical or pathological phenotype is not enough. So both the clinical manifestations and the pathology are due to phenotypic convergence, both in the liver and in the brain. Of course, the brain is a little bit more sophisticated than the liver. So it has many different results from whatever causes. The poor liver can only become cirrhotic. The brain can develop different disorders. But for Alzheimer's disease, I think this is phenotypic convergence that can come out from different causes. So what is Alzheimer's disease? I'm talking about this sporadic form of Alzheimer's disease. It's not a genetic early onset Alzheimer's disease. It's a complex progressive neurodegenerative disorder caused by a heterogeneous combination of environmental and genetic factors. Heterogeneous combination. So unlike cirrhosis, in which a good doctor can find out what is the cause of cirrhosis in that patient, the cause, one cause. This is not the same in Alzheimer's disease, where there is a combination of many contributing factors which together bring this deterioration of the brain. So because of this complexity and etiological heterogeneity, it is not even a disease in the classical sense that when I went to medical school I learned about. So Alzheimer's disease, we heard this now 20 years ago, and it's time to get rid of this hypothesis. Cost us so much money, so much effort. The great tragedy of science, said Thomas Huxley, is a slaying of a beautiful hypothesis by ugly facts. So it was a beautiful hypothesis, the amyloid hypothesis, but the facts are not there. We should eliminate it and think afresh. So looking for the magic bullet, complex problems have many simple solutions, which I mentioned before, but simple solutions are wrong for complex problems. We must have more sophisticated things. So Karl Popper, a great philosopher from last century, said the definition of a theory to be scientific is that you can prove it or disprove it. And in fact, this is not what happened in the amyloid hypothesis of Alzheimer's disease. And you cannot disprove it. Whatever you do, they will come up with a different reason why it should be so. So there were moving targets. First we thought about plaques. Then we thought about monomers or fibrils or dimers or trimers or protofibrils. Where are they? Extracellular, maybe intracellular. When? Now they say that maybe we started the treatment of Alzheimer's disease with anti-amyloid drugs too late. But this, and should have started early. But these people who come to us for diagnosis of their cognitive impairment, and we can tell them too late, all they say is, I want to remain the way I am now, not to get any worse. And they continue to degenerate. What is the cause of this continued degeneration? If you understood this, and we say that it's not related to amyloid because anti-amyloid drugs do not affect it, then this process, which causes them to further go down, when did this start? And if we know what it is, we could ask ourselves, maybe it started from the beginning. Why think that amyloid was the cause then? So many failed theories, and I think the reason is that all dementia is mixed dementia. Of course, you have presenile mutation carriers, IP mutation carriers, which have pure Alzheimer's disease, pure dementia. You have some people who have vascular dementia, pure vascular dementia. This can be CADASIL mutation carriers and so on. But for the older people, for most people who are composed of this epidemic of Alzheimer's disease, they have mixed dementia. And again, something that I wrote a long time ago, that the most common type of dementia is not Alzheimer's disease, not vascular dementia, but mixed dementia is the most common. Because in old age, you accumulate disability, you accumulate, the brain accumulates damage. So all of us, even the younger ones, already have some changes in the hippocampus with neurofibrillary or tau impairment. And all the people in this room have some atherosclerotic changes. We'll hear a lecture about atherosclerosis next in this lecture. It begins in early adulthood. So anybody who's in their 20s or 30s, if they are victims of a road traffic accident, it can be shown that they have deposits of cholesterol in their aorta, and maybe also in the brain. So it accumulates over the years. So the take-home message are the following: that senile dementia is a complex progressive cognitive disorder characterized by brain atrophy and frequently deposits of plaques and tangles, but not always, caused by a heterogeneous combination of environmental and genetic factors. And because of this complexity and etiological heterogeneity, it is not a disease in the classical sense of the word. And amyloid and neurofibrillary tangles are downstream markers unlikely to be associated with the pathogenesis of the disease and therefore unlikely to be useful drug targets. So for what we should call senile dementia, not anymore Alzheimer's disease, we should go back to the term that we've used several years ago. Senile dementia has intrinsic causes and extrinsic causes. The intrinsic causes may be genetic, for example, ApoE4 and other things. Extrinsic causes, what are the extrinsic causes? We know about them already. We know many of them. And if we think about this, the important message is that we cannot cure Alzheimer's disease. We cannot reverse aging. But we can prevent this if we look for the risk factors. And to talk more about this, you're all invited to CONI. We come to Athens this year, so I'm very happy to see you here and to see you there with Professor Vadikolias as my co-chairman. And just to tell you about the dementia program that we have with Lefkos Middleton and Magda Tsolaki as the chairperson of these sections. And we have an excellent program, debates. So this is pro-con debates. In 1 hour each, is senile dementia of Alzheimer's without pathology a preclinical stage of Alzheimer's disease? And Kurt Jellinger will say yes, and Leah Greenberg will say no. Animal models for AD have led us nowhere. Magda Tsolaki will be the host. She will explain what is going to be discussed. Marwan Sabag will say yes, and Spiros Georgopoulos will say no. Diet and dementia, still an unresolved issue requiring further nutrient mechanism-based research. And you had yesterday, there was an interesting discussion about nutrients. Nicholas Skarmias will be the host. Roger Bullock will say yes, and Evangelos will say no. Does cognitive reserve prevent neurodegeneration? And Robert Pranesky will be the host. Panos Alexopoulos will say that it's neuroprotective, and Eder Arzanga will say that it's purely symptomatic. And we go on and on for one full day with debates, 1 hour debate each. So one person, so Magda will be the presenter of the problem, then somebody will say yes, 10 or 15 minutes, somebody will say no, 10 or 15 minutes, then they will have time for questions and comments. They will have a couple of minutes for a rebuttal, and then we vote. We vote both at the beginning, at the end, who think A is right, who think B is right, and we make a vote, and so we have some fun. GWAS in AD are a waste of time and money. Can sleep measurement tell us about the neuropathology underlying dementia? Is mild cognitive impairment a useful concept? And I will talk about this later today, so you can hear my views about this in a few hours, which is the main factor responsible for the reduction of dementia incidence, because you know that there is a reduction in recent years. So again, a debate about that. And then we have a series of special lectures. How low-risk genes for AD are really important, and Cornelia Van Duyn will talk about this. The tau connection, what is going on with tau, not only in Alzheimer's disease, but also, of course, in the other tauopathies. What can genetics tell us about human memory? Andreas Papasotiropoulos will come over to tell us about this. Why we have failed to cure Alzheimer's disease. This is a pure lecture that you may not be interested to hear anymore. Non-pharmacological intervention in dementia, Magda Tsolaki will tell us about this, and innovative technology for cognitively impaired people. Luisa Spiro from Romania will talk about this. So we are all invited, an exciting program. And of course, the program in CONI is not just dementia, just what we have in dementia. We have in the parallel hall stroke or epilepsy or migraine or Parkinson or what have you. So a lot of activities, so please come and join it. Then we have the Dementia Roundtable, Research, Innovation, Social Support in Greece. So this is, since we come to Athens, we want to hear what is going on here. So we have a series of lectures, presentations about this, again, by Professor Tsolaki, Zanagas, Elizabeth Kapaki, Zigouris, and of course, Professor Saka. So please come, and you know, this is an opportunity for Greek people. We know that the chances for you with the economic situation now to go to international meetings is not very good, but here is an opportunity to come to an international meeting in your home country, which is, of course, much cheaper. We have special prizes for local participants, and you can present and get feedback because there are opportunities to do that. So I hope that to see many of you and your friends here. There are flyers outside. Thank you for the opportunity to present this. Thank you, Magda, for your wonderful cooperation over the years.
Thank you very much, Amos, for this excellent presentation.